Hi, everybody. It's kind of nice to do these events because sometimes I see people I haven't seen for a very long time, which is really nice. So Mary Scheinman, for instance, that it's really nice to see you. I'm just going to quick review a couple things about lung cancer and then get straight to screening. So lung cancer is the most common cause of cancer mortality in the United States and around the world. And these are the cancer death rates. This is American Cancer Society data that go back to, where's my pointer? No. Golly, this is a two-fisted thing. To 1930 to the present time, there's always a little lag there. And lung cancer is this red line. This is men and this is women, and you can see the epidemic really clearly starting back in, noticeably in the 1950s in men and later in women, and it mirrors the use of tobacco in this country. And so both of these curves are trending downward, finally trending downward in women. But the bottom line is this is going to stay the same for all of our medical lifetimes, and lung cancer mortality is going to remain a huge cause of death while all of us are taking care of patients. And so if you look at 5-year survival rates, which is kind of the cancer metric for breast, colon, prostate cancers, which are the other 3 common causes of cancer death, common solid tumors, you'll see that over the past decades, there's been an increase in the 5-year survival for all of those. And you could argue about why, but some of it's related to focused research, and there have been more NIH and NCI dollars spent on these tumors than lung cancer, leading to better treatments. And then all of these tumors have methods of screening that we could argue about whether they're really efficacious or accurate, but they're certainly embedded in our medical practices and accepted by our patients. And over that same time frame, the lung cancer 5-year survival has really not improved a lot, and we get really excited when we hit 18% because that's a statistically significant increase over 13%, but it's because it's a small increase in a small number. And so here is the challenge, and I think it points out that we have needed for a long time a means of early detection. So you all know that screening is evaluation for disease in a healthy patient, and it makes sense when outcomes are better if the disease is detected early, and when the benefits of the intervention outweigh the harm. And the gold standard of a successful screen is that you can demonstrate a decrease in mortality as opposed to a decrease in survival. And so it's true for lung cancer and for every other solid tumor that if you detect tumors early, so a stage 1A is essentially a solitary pulmonary nodule, no involvement of anything else. That's this blue line, that's the survival curve. It's better than if you diagnose it when it's locally advanced or when it's very advanced, and the staging shows you that the higher the stage is, the worse the outcome. And so I think lung cancer is a disease that really was crying out for screening. And when I was a fellow back in the 1980s was the time when it was proved that chest X-ray is worthless for lung cancer screening. That essentially left us with doing nothing. And so we waited a long time for the National Lung Screening Trial. It was published in the New England Journal in 2011. 52,000 patients participated in this. It cost the government $250 million, and it took like 6 years to, actually more than that, to finish. And so the entry criteria were ages 55 to 74. You had to have at least 30 pack years of smoking, and you had to be a current smoker. You had to have quit within the past 15 years. And that was to get a high-risk population. Patients were randomized to an annual chest X-ray versus an annual low dose, meaning low radiation dose, chest CT scan. There was a trial that was going on in parallel, the prostate, lung, colorectal, ovarian screening trial that was looking at chest X-ray versus nothing. And the NLST banked on that study showing, again, that chest X-ray was not worth doing, and it did demonstrate that. And that is why there was no arm in this trial of no screening. And I think what you can see is that in the years since randomization, this is the number of cumulative lung cancers, that there were more lung cancers diagnosed in the screening with low-dose CT group than in the chest X-ray group. But the numbers of deaths in the low-dose CT group were less. And the target was to get a 20% relative reduction in the low-dose CT screening arm, and that actually was achieved early, and the study was stopped early because the endpoint was clearly going to be met. And so this was the first time we had proof that a lung cancer screening intervention actually decreased mortality. And I would point out that the risk of lung cancer in that study population was 2 to 3% over 6 years, and we know that exactly because they were followed for that period of time. The majority of screen-detected cancers were early stage, although there were a lot that were not. And the number needed to screen to prevent one lung cancer death was 302. And so this is the entire conclusion in that New England Journal of Medicine article. It's the shortest one I've ever seen in an abstract. Screening with low-dose CT reduces mortality from lung cancer. That was pretty powerful. And so fast forward, 4 years it took for Medicare to approve this. And you mentioned the USPSTF. So the United States Preventive Services Task Force advises Medicare. And if USPSTF says screen, Medicare is obligated to pay for it for the Medicare population, and the private insurers tend to follow what Medicare does. And so CMS stated that the evidence is sufficient to add a lung cancer screening, counseling, and shared decision-making visit, and for appropriate beneficiaries, annual screening for lung cancer with low-dose CT as an additional preventive service benefit under the Medicare program. So as of February 2015, this was paid for, though it took a long time for them to issue codes. But there's a catch, and the catch is there's a lot of, you must also do these things in order for the patient's screen to be paid for and for us to be reimbursed. And the first part is up to us. The patient has to meet these criteria. And Medicare increased the age of the screen to 77. In the NLST, it was 74. USPSTF, based on modeling, suggested 80, that you should screen to age 80. And I figured that Medicare took 74 and 80 and split the difference. But it actually is that in the NLST, they were followed for 3 years, and so many of them became 77 in the course of the trial. And so they have to be this old. They have to not be worried about cancer, so they can't be like coughing up blood or having a cough or anything. They have to have smoked the 30-pack years, and they have to have been smoking within the past 15 years or smoking now. We must prove, Yale New Haven Hospital must prove that our radiologists, who are actually sitting over there, Irina and Isabel are part of our chess group, that they have read this kind of study. They have to have read, I forget how many of hundreds in the previous year, and they must be using a standardized template to read these. This is called LUNGRADS. It's the reading template from the American College of Radiology, and it is essentially the only one out there. And so if you're getting back lung cancer screening studies that say, according to the Fleischner criteria, they're using the wrong template. You have to have a reporting system. You have to make available smoking cessation interventions, which you may be doing in your office, but we can offer when they come for their screens. And importantly, for the initial screening service, so the first time you order that screen, you must provide and document this lung cancer screening, counseling, and shared decision-making visit. And this is actually very spelled out in the Medicare. It's like 42 pages long if you want to go read it. And we know that we're all doing this in our offices, but we're not necessarily documenting it. And this is supposed to be a separate visit. If you are billing for it, it should be a separate visit dedicated for this purpose. Okay, there's also this registry that we managed to set up in Epic with the help of Nitu and a whole lot of other people who spent a lot of time doing that. And so the benefit, I already told you, is this 20% relative reduction in lung cancer mortality. What does that mean? That means in every 1,000 persons screened over this follow-up, there were 3 fewer deaths from lung cancer. But 21 people would have gotten lung cancer and died in that 1,000-person cohort, and 18 of them are still going to die. And so we saved 3 people, but we can't do anything about these 18. And then our medical oncology colleagues and our surgeons have to take over. And so that's an important thing to discuss with patients. It doesn't mean you're not going to get lung cancer. The risks are there's a huge high false positive rate. 96% of all the abnormalities, these nodules you see on radiograph on the low-dose CT are not cancers, or they're cancers that are not destined to kill you. So we have to deal with all of that. People get worried, we get told there's a nodule, and so we order more testing. That's more radiation exposure, more expense. And even in the National Lung Screening Trial that was done at all these tertiary centers with all of this oversight, there was an increase in invasive diagnostic procedures done in patients who had benign disease. And so the only reason you found it was because you did the screen. And then what we have seen at Yale, and people are finally waking up to, is there's also this increase in identification of incidental findings outside the lung. The thyroid nodule, the adrenal nodule, the coronary calcification. All of that stuff comes back then, and you have to deal with that in this screen that was supposed to just deal with the lungs. So I'm not going to walk through this, except you and I refer the patients for the screen. It's determined at the time of the order goes in if the patient's eligible, and that's done at the imaging place. They pre-auth it. We actually offer a separate decision support visit free of charge to the patient. We don't generate any income from this, but we felt this was such an important part of this, particularly because predictably a quarter of patients every year there's a 25% chance every year you have a scan that you'll have an abnormality. And forewarning patients about the 96% false positive rate is a very powerful thing when they can see their studies in EPIC and they panic because there's a nodule. And in lots of studies that have been done, people know that nodule means something about cancer. And so they interpret that as I have lung cancer. So that Polly Sather, who is here actually and is going to pass around our iPad, does this decision support visit. It takes anywhere from 20 to 30 minutes with the patients. We've surveyed them. They find it's incredibly helpful. One person so far out of the several hundred has opted not to have their screen based on his risk, which we could show him, and the potential downsides of finding something. And that's what this decision support thing is all about. They go for their screen directly from the visit with Polly. The reports come to us. We don't do anything about them. But we make sure that if there's an abnormality that you know, and we felt that was our obligation if we were going to be involved in all, to at least flag you, there's an abnormality there. And then if you choose to refer back to our nodule program, we can do that too. And we have the backup of the whole thoracic oncology program. So Karen, I'm really glad you're here because it's so hard to order this in EPIC, and it partly is because it just changed. Okay. And so you should order initial lung cancer screening for the first time you send the patient. It sends the order to EPIC, or you can fax this in if you're not in the EPIC system. It automatically generates the visit with Polly for the decision support. And again, that's no charge to the patient. And it enrolls the patient in the tracking system, which as we're entering our first year, should send a note to you that the patient is due for their scan. And then the subsequent lung cancer screening is just the subsequent screen, but it doesn't need this decision support visit. It's only mandated by Medicare for the first visit. So this is what the order looks like for that initial screen. And you would put in lung cancer screening, and you should check yes, 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 if the answer is truly yes, yes, yes. And if one of the answers is no, the patient actually shouldn't be screened because they don't meet criteria. And I'm going to say one more word about that. And then you click whatever you click, accept. And that should go off, and it goes to diagnostic imaging. Yes?
Isn't like every single current smoker, the vast majority of them, or 75, don't they all have a cough?
No, most smokers are not coughing. And most smokers aren't short of breath. Only if you look across the smoking population, and don't tell this to your patients, but only about 20% of them have physiologic abnormality. So only about 20% will have chronic bronchitis with sputum or wheeze and have measurable spirometric abnormalities. And so if the patient has a cough and has had a cough for 20 years, they can get screened because they're at their baseline. They're healthy. They may have a cough, but they're not sick. If they're coughing up blood, then they're sick, right? But if they chronically have a little cough, or they chronically have a little shortness of breath, or anything like that, they chronically have a little sputum, they qualify as healthy, and they would be screened. Yeah.
There's a magic code. How do you get a diagnosis?
Yeah, so hang on, it's coming. And so for this initial thing, you have to do all these things. You have to have the shared decision-making visit. It has to be performed by a mid-level provider or a physician. You have to make sure the patient's eligible. You need to do that shared decision-making thing and then provide the counseling, the subsequent things. You don't have to document all that. And one important thing is that a lot of these patients are still smoking, right? And somehow the intervention of screening in the National Lung Screening Trial, even though there was not a dedicated smoking cessation intervention, this is what happened to the smoking rates. And it happened whether your scan was normal or whether you had a major abnormality that looked like it was suspicious for cancer. So we'd expect this red one, right? And so what was a little surprising was this blue one. So that whatever you're doing when you are talking to the patient about screening, that tobacco intervention at that time is probably meaningful. That's called the teachable moment. Not everybody is convinced that that happens, but I think it happens. And actually, you talked about research, and there is embedded now into the clinic one of the research assistants who's recruiting for this study that's embedded in the spore. And actually, there are several trials going on, and they tend to be related to helping people quit smoking, right? So that I'm going to quickly go through this. You can do the decision support in your office if you choose. There are several tools online. One is from the American Thoracic Society. There's one from the VA. There's one from the University of Michigan, which is really good, and those are all free on the web. And Polly, I think you can pass that around now. This is what we use. This is an iPad, and Polly's got it in her hand. And we actually developed this educational model and the decision support tool 4 years ago when we first started screening. It goes through this very quick, mostly cartoons, but it also goes through why do you want to be screened? What do you think your risks are? What is motivating you to do this? Also, we go through with the patient this personalized lung cancer risk prediction model. This tool is online, and you can get it if you want to use it. You just enter these things that we pretty much know about our patients. How old are you? What ethnicity are you? How much do you smoke? And when did you smoke? And it spits out for you at the end the probability of lung cancer over 3 years. And this 65-year-old guy who was smoking a pack a day for 25 years and quit 20 years ago has a 4% risk of lung cancer over the next 6 years. That's actually almost twice the average risk of people who were in the National Lung Screening Trial. But you'll notice that he quit smoking long enough ago that he probably won't get Medicare approval for screening. And that is a dilemma that you have to deal with patients in your office. And to some extent, that is what you can use the decision support for also. And I'm going to stop there. The Yale Lung Scan group is a big group. These are just the people who were primarily involved in the beginning when we were putting it together. Thanks.